Older Americans that were usually unable to work were barely making ends meet with Social Security benefits. On top of that, many either did not qualify for health insurance or they couldn't afford the premiums on Social Security alone. The medical field was controlled primarily by private businesses, and there were several legal messes due to that fact. Several nonprofit hospitals and blood bank companies showed a disinterest in quality work, favoring profit over people. The nonprofit hospitals received the benefits of being tax exempt, but pursued collecting profits from patients in the same way a normal hospital would, while the privatized blood banks were all but closing down voluntary blood donation sites to promote their blood that often came from a population that was poor and was not well screened for blood-borne diseases like AIDS. Insurance companies followed this trend and would often switch from a nonprofit to a for-profit status without state approval. This made it difficult for seniors and impoverished citizens to receive medical care due to the lack of insurance. Social Security assistance was not enough, as older Americans required more than twice as much hospital care as people under the age of 65, and many were unable to work. The need for support for elderly Americans was painfully clear. This review will be broken down into 4 objectives to better analyze the program. My first objective in this policy review is to give the context about the policy's origin. After giving the history of the policy, I will define its objectives and goals. My second is to lay out how the policy is implemented, particularly as it pertains to Kansas. The third objective will be to outline where the policy meets its goals and where it falls short. The last objective will be a summary of what I have found and recommendations for the future of the policy. Medicare is a primarily federally funded program that provides medical insurance to elderly or disabled U.S. citizens. Parts A and B are often referred to as Original Medicare. Part A insures your hospital stay. This includes hospice, which could be important if the recipient develops a fatal illness. Part B covers more preventative care coverage. Part C is also referred to as Medicare Advantage and essentially replaces Part A and B with its own federally regulated plan through a private company. Part D covers drug costs for those with Medicare. There is also something called Medigap or Medicare Supplement, which can cover deductibles as well, which also is sold by a private insurance company. The primary objective of the policy was to make healthcare more accessible for the disadvantaged. This includes both seniors and the disabled. It began on July 30th, 1965, when Lyndon B. Johnson signed both Medicare and Medicaid into law. During this time period, there were many issues surrounding the privatized nature of the healthcare industry. There were nonprofit hospitals and blood bank companies that were not providing quality care. Insurance companies followed this trend and often would switch from a nonprofit to for-profit status without state approval. This made it difficult for seniors and impoverished citizens to receive medical care due to lack of insurance. This blow to older Americans led a growing public interest in the topic. A Democratic president and some Republican bipartisanship led to the creation of Original Medicare and Medicaid against conservative protests. Public opinion supported the bill, starting with the support of 2/3 of the public in the 1960s, to 8 out of 10 Americans polled approving the bill after it was passed in 1965. Many conservative legislators did not support Medicare or Medicaid for that matter. This caused Republicans to be split on the issue, while Democrats favored it by a majority. It managed to receive enough bipartisan support and the support of the public to pass. Both Medicare and Medicaid are run by the Centers for Medicare and Medicaid Services, or CMS. This group is a branch of the Department of Health and Human Services, HHS, which is part of the federal government. Recipients of the program must be a U.S. citizen, ages 65 and older, or be diagnosed with a condition that impairs them to the point where they cannot work. The eligibility requirements are based mainly off of age and work history. The person must be a U.S. citizen of one of the 50 states or territories, ages 65 or older. They must also have worked in the United States and paid into the program for at least 10 years. Younger recipients have to have been diagnosed with a condition that has left them disabled to the point where they cannot work for a period of 12 months or longer. They are required to have worked a U.S. job for 10 years prior to enrollment. If the person's disability can be treated, they can be denied coverage for not following the doctor's recommended treatment plan. Certain diseases that would cause someone to enroll in Social Security disability will automatically enroll them in Medicare. Given that this is a federally funded and operated plan, it is implemented the same way in Kansas as it is in any other state. Only the parts of the plan that aren't fully run through the federal government, for example, Parts C, D, and the Medigap coverage, for instance, are still regulated federally, but they are processed through private Kansas businesses. Medicare has provided a boon to the medical field in general. It provides hospitals with an influx of patients, and this increases the demand to hire more people into the medical field, which also helps the economy. Due to the surge in extra patients, the medical field developed quite a bit of revenue. The influx of patients also helps the hospital in the process of training new doctors and nurses. Often this competition leads hospitals to focus more on their quality of care, and this leads to more certification, or in some instances, recertification, where previously they might not have been as knowledgeable. New equipment was attained. Investments were made in new facilities to meet the demand. This also led to new hospitals developing as well. This is particularly beneficial when considering how little access rural areas have to hospitals. Due to the influx of income in the medical field, more money is capable of being earmarked for research and development. The development of new treatments has exploded over the past couple decades. For example, various new cancer treatments have been developed and are being tested. There are around 48 million people using Medicare. It is difficult to rate the quality of healthcare received by people on Medicare due to the development of the medical field as a whole over the years. Measurements might be skewed in a positive direction due to the quality of medical care increasing over the past several decades. However, one area that Medicare's role is clear is prevention methods. Prevention and early intervention can lead to lowered costs associated with illness. Prevention can contribute to shorter hospital visits, which in most states cost over $1,000 per day. Psychological evaluations are also more accessible to seniors, an age group that can most benefit from them. Medicare eligibility has also been linked to an increase in other screenings like cancer. One of the largest issues with Medicare is that its opponents have an issue with its cost. The 2016 statistics show that Medicare took up 15% of the nation's budget at a cost of $588 billion annually. It is also projected that that amount will increase by 18% over the next 10 years. Another issue that the Medicare program has is the fraud it generates. This year alone, 412 doctors were charged with medical fraud. A large portion was linked to Medicare and Medicaid with ties to the opioid epidemic. The program also has distribution issues. Recipients in the 85 and older range spend 3 times more than those younger than them. This problem could be spread across the demographic, taking some of the weight off of those most financially burdened. In addition, many seniors are unfortunately dual eligible for both Medicare and Medicaid due to living in poverty and require to be enrolled in both in order to receive more care. This means the policy does not fully meet its goals without combining with another policy. Medicare has been a huge benefit to those it has reached. In its current state, it is expensive and does not reach everyone it potentially could. Overall, it is a bit outdated at this point and could use a reform to fit our current population, medical, and financial needs. However, that does not deny the amount of help it does do for those who are using it. Preventative care is more common, and the overall health of our elderly has increased. The ripples of its effects are seen in the stimulated medical field that we have in the U.S. A single-payer Medicare for All plan could distribute the cost by sharing the debt between all U.S. citizens. This would reduce the cost exponentially. The problem of Medicare and Medicaid not being fully successful alone would be alleviated. Including healthy young people in the distribution would lower the amount that each person would have to pay and would alleviate a financial burden that affects everyone. There are several other nations that employ this method, and their medical standards have increased because of it. This would not only be a more effective solution, but a fiscally responsible one as well. The policy is not without flaws, and could be modified to better serve its original purpose. However, not acknowledging the positive effect Medicare has had would be a disservice to the large amount of people who are positively influenced by it. If it would be replaced with a lesser program or not replaced at all, then it should be continuously conducted. There is value, however, in replacing it with a more successful concept like a single-payer Medicare for All program.